So today we'll be talking about the a whole of life course approach to women's health. We've been hearing a lot about women's health, and I keep saying 2024 is the women's health is back in fashion in 2024. But then why do we want to talk about a life course approach? A couple of things to note is our life expectancy has increased. We are living longer, and especially women in sub-Saharan Africa. Our life expectancy is up now to roughly the 60s. During the peak of the pandemic, our life expectancy was around 37, 41. And so what that means is because we're living longer, we're living much longer, more years in disease and debilitating conditions. There's a McKinsey report that showed that women spend 25% more time in poor health than men. So we now have a lot longer time to spend in poor health. The same McKinsey report showed that the conditions that are causing us poor health are actually not where the investments are. 5% of these conditions are maternal or women-specific conditions. 51% are conditions that affect women differently or disproportionately. And for 44% is we don't know. We don't know how they behave in women compared to men. And we also know, again from that report, that the things that are causing us ill health are more the debilitating conditions rather than the conditions that cause mortality. And we know there's been a lot of focus on mortality. And so I'm really excited to have Dr. Ebere, who I've been stalking for a while, to join us for Diagnostics Day to try and explore how we chew gum and walk at the same time, because we still need to focus on what we've been focusing on, but we still need to acknowledge the changes in women's health and the fact that we're living longer, our conditions are changing, our disease burden is changing. But what does that look like for our health system? So thank you for finally agreeing to join us.
Thank you for having me. It's a pleasure.
So, Doc, when we think about women's health, particularly in low-middle-income countries and particularly on the outside of the world, traditionally we're thinking about sexual reproductive health. And this is important issues, core issues. But we've known for a while that women's conditions are beyond sexual reproductive health. Why are we struggling to make this shift?
So, first of all, thank you for inviting me to join you here, and it's a pleasure. It's been a very intense WHA week, so I'm looking forward to so those of you who might be a bit tired, I'm going to shake you up a little bit. So I'm going to start by declaring my own bias. I am very pro-women. I'm a woman. That gives me the right for that. And I am also very unapologetic in challenging the status quo. So you asked why we are still just focused on sexual and reproductive health when we consider women's health. And that's because women aren't seen as a whole person. We're an appendage. We're seen as, the purpose we serve in society is to produce the next generation of taxpayers. And therefore, the interest is all exclusively on that reproductive age period. And once you pass that reproductive age period, you're discarded and ignored. And so that isn't a health issue. It's a system, society issue that we need to address. And it doesn't matter what we do in the terms of health and science to innovation if we don't actually address the system that refuses to see women as a whole person, as a full entity, as significant, and 50% of the capacity of humanity. So that is, in my view, the main problem. And we're not going to tackle it by just talking about it from health. We have to talk about it in every space, in every society. We have to address the systemic biases that keep women and keep the focus on women marginalized and reduced to that 1% of our anatomy.
We could close here and we're done because... So what does this look like in terms of getting the system to see us as more that hit home, to see us as more than just a sum of our reproductive organs or just a function of reproduction?
Well, that's the challenge of inequities and every ism that there is in the world is actually how do you change the way society has chosen to box people in, whether it's because they're women or because they're black or because they're poor. And the first thing is actually, you have to keep talking about it. You have to challenge the status quo. You have to provide the evidence of what we lose as a consequence of that compartmentalization. So if you are going to war with, half of your army, I mean, you are going to lose. And we are in the globe going to war with half of our army. And again, I have declared my bias. I think the actual more innovative part of that army is sitting at home, having babies, and not being allowed to return to the workforce after they've had babies, or not supported to when they do return. So we need to actually change the conversation to stop thinking about women as an addendum, an extra. And to do that, you have to change who's leading the conversation. And that brings you to, my particular passion, which is how do we get women into leadership in every sphere. In health is very, very important. Not just getting in there, but keeping them there, supporting them to be effective there, and actually making sure that they thrive. Because if they're supported, they can get in, stay in, and thrive, then they can actually start to challenge the status quo. What we tend to see is that there is a lot of tokenism in the response to say, okay, we've got a director who's a woman, box ticked. And we've not actually considered whether that woman is going to be supported to be effective in that space. And when that person's term is done, is there another woman in the pipeline? So we need to change the leadership of the system so that we can challenge the status quo. So long as we still have, and again, I will keep saying, apologies to the men for my bias, so long as the system is led by predominantly gray-haired white men, we won't change this because they don't actually see the problem. Those of you who on social media, there was some American, that thing the Americans call football, it isn't football, gentleman who gave a speech at a graduation and basically told the women the best thing you can do in life is go home and have babies. We have to stop giving such people platforms, and we need to change the people who actually speak up in the space. So it's not just about more women speaking up, but it's about men actually understanding what the problems are, listening, and then being actual effective allies in the conversation. One of the positive experiences I've had from male allyship was where, as you know, these days, manals are rare. It's getting increasingly rare, but they still happen. And where a male ally demonstrated that allyship by refusing to take his chair unless they could prove that there was no woman qualified. And just in that audience, 3 women stood up and took that podium. So it can be done, but you have to be intentional about it, and we need to be consistently vocal about it, and we need to back it with data. We know that there is information that demonstrates that women are useful contributors to factors. You only need to look in health. If women took an hour off work globally, and actually it's something I would really like to encourage, we just went and worked through 1 hour, one day in the world, all women down tools and say they're not doing any care work. What do you think is going to happen?
The collective shadow of the men in the room. Have to take care of the babies. Going back to what you said about women in leadership, we know, especially in global health, the higher you go, the male it becomes. And when we think about, in fact, last week I had somebody say, was giving an example about how they tried to get cancer diagnostics introduced into the system. I don't remember which country, would probably safe not to name the country. And for prostate cancer, because the Minister of Health was a man, it was a no-brainer. But for breast cancer screening, it was a slog trying to push it through. And I wondered to myself, would this change, would we be seen more as women in our totality by the health system, with more women in senior leadership, or is this getting the male allies to be better allies?
It's both. It's both. So it's not just about having more women in leadership, it's actually having women heard at every sphere and every tier of engagement. There is a perception out there that, I don't know about how many women here get very uncomfortable when they keep saying you're a strong, resilient woman. I actually don't like that. It is because it's an excuse to not actually address your pain. When I was in medical school, we were taught that myocardial infarctions tended to be silent in women. I understand that more modern research is actually, it isn't silent, their symptoms are ignored. So the conversation has to happen at every sphere. We need to empower women in every space to be able to articulate their needs, express them, and then work with the men to listen. But while we're doing that, you have to actually change the system. It can't rely on just goodwill. So the importance of the initiatives around, I know it's now a dirty word in certain parts of the world, diversity, equality, and inclusion, is by being intentional to look around in every space and say, whose voice isn't being heard? And in most cases, it's the women. So we need to actually build into those systems at every stage representation and enable that representation to be effective. So in research, for example, which is relevant to what we're talking about here, we don't even include women in studies. We don't have women as research PIs in all sorts of research studies. Even when women are included in the study populations, the analysis isn't done by gender, so we don't even know what the impact is on women's health. Now, there is a difference when you have somebody who's underrepresented in the space able to ask, why haven't you? Because if we're in if you're used to seeing a room of investigators that are all male, you don't actually realize what's missing. But if there's a woman introduced to she says to you, why are you all male here? But we need to actually support women to be able to vocalize those things. We need to be very intentional about looking around the room, even if it means you have to have a checklist that says every meeting, can you check who's not here? So we need to be intentional about it. We also continue to advocate for men to be allies. And then those of us who are privileged enough to have a position need to do what I'm doing now, which is challenge the status quo. But not everybody is in a position of empowerment or comfort to be able to do that. We have to recognize that. We support them, and we use other mechanisms. Sometimes it's more effective to go behind the scenes than to stand on a podium. I'm about to retire, so I have nothing to lose. and challenge the status quo. So we need to recognize that. And then when women do get in, the stories of burnout are so common because it is very difficult to be the only anything. If you're the only woman in a leadership position, it is very difficult, it's very lonely. So when we do get women into leadership opportunities, we need to support them. That means, and I say we, I don't mean just women, I mean the organization, the institution, the system needs to support them so that they don't feel alone and they're supported and they can grow and thrive. And then we have a pipeline so that we don't just have one woman tick the box and then nothing changes for the next decade.
I was telling one of my female colleagues at work that the prize you get as a woman for doing an excellent job is more work. And you've been at this for a while, the building fighting for women in global health leadership and mentoring and building women in global health leadership. And especially African women, Asian women, women of color, and younger women going up into the system. Is it getting better? Is this, because you said you're retiring, you're leaving this burden to...
I'll use the Serena terminology, I'm transitioning. Okay. No, but it is getting better, but not at the pace I would like to see. I would like to see it getting better faster. I'm also recognizing, like I said, that even the pipeline is expanding and lengthening, but there are still bottlenecks to the top. And like you said, women that tend to get, when they get supported into leader or given the opportunity in a leadership position, it's almost as if the system then takes away all the support mechanisms and says, go on then, fix it. And so it's almost like they're being set up to fail. So we need to address that. We need to recognize that just because we've got one woman in there doesn't mean the problem is solved. We need to continue to drive that. It is improving. I think that the next generation of women are going to be, they are amazing, and they are not going to, they will knock down the infrastructure that is a barrier to them. That's my belief. And I also believe that globally, the system is big, the patriarchy that doesn't see women as a whole being is creaking. And it's wobbly, and it'll take just a continuous nudge to topple it over, and then we'll open up and have something new, because we have to have a new system. Everything else we're doing is tinkering on the edges.
And I want to go back to something you said earlier about when you're talking about myocardial infarction and pain. And pain for women is actually one of the symptoms that's largely ignored. And even gynae pain, so we talk about the bulk of the work that we do is focus on sexual reproductive health, But even the bits that we're focusing on, we're not focusing on everything that we should be. And yesterday someone asked me a question, because if you think about what we don't know, there's a whole bunch of things we're not looking for, either because they're not a priority, there are no diagnostics for it, there's no global fund for that. And somebody asked me yesterday that wouldn't it be better to focus on one thing and do it well and deal with it and then move to the next thing? Because when we start expanding to all of these issues for women, then suddenly it becomes health, and it starts to get amorphous. It's now health, and I'm curious to know how you'd respond to that.
I'm sure the question was from a man. And the question I put to him is, would you guys have been okay if we didn't have Viagra? That's just one thing. We could focus on prostate problems and ignore that. It's, again, about looking at the whole individual. You cannot look at women, even if you're only interested in reproductive and maternal and child health. The factors that lead to adverse health outcomes in pregnancy are established long before that person actually reaches childbearing age. Most women in low-income countries, in particular in Africa, are already severely anemic before they get to childbearing age. So you can't only become interested when they're likely to start to have babies. You have to look at people as whole people. And since most of the caring responsibility still sits on women, the responsibility for raising the next generation is going to be held by somebody whose whole health hasn't been considered. So I don't think it's one or the other. If you want to focus, then the focus is on, you're focusing on 50% of the global population. Whatever it is, if you're taking a life course, they're responsible for the next generation biologically and socially as well for now, although I'd like to see that changing a lot more at a lot faster pace, because the only biological imperative is to actually give birth. But after that, there is no gene that makes women the only people who can care. So we need to change that. But if we just say, okay, let's only focus on maternal, mortality and, directly linked to childbirth. Well, we've been focusing on that for decades. How well are we doing? We're still doing really badly. In fact, some of the successes have started to reverse. And that's because we're only looking at that short period of time. If we took that whole life course approach and actually start from the beginning and say, from the birth of a girl child in a society, or in many societies where there's still a social preference for boys, what happens? How are we already setting up this child, this girl, for adverse maternal outcomes, because as a child she's more likely to be undernourished, she's less likely to be taken to a hospital if the resources are limited in the hospital. If there's a son, he's more likely to be taken to healthcare. So if we don't start looking at it at the issues that, even if our interest is still only in the reproductive years, the issues that matter start then. Women who get access to education are more likely to take to be part of antenatal care, and therefore their maternal outcomes are better. But it also comes down to a critical issue about listening to women. I mean, I'm those of you who haven't picked it up already, I'm a huge fan of Serena Williams. So her story about her experience in pregnancy and almost dying, and this is a very articulate, very wealthy, empowered woman, and she wasn't listened to. So imagine, multiply that by thousands for the average woman in any society whose pain is ignored. I'm from Nigeria. There is in my part of Nigeria, there's a belief that women get to a certain age and they have some sort of immunity against pain from heat because you pick up a pot off the cooker without and those sort of, tropes that mean, and there's a recent fad around these labor pain simulation things that men are wearing, and they think, and the response is actually, I'm not happy with it. The response is, oh God, you women are powerful. No, the response should be, what do we do so you don't have to go through all that pain? That means we actually need to stop looking at it as women are built differently and they can tolerate a lot more pain and trauma than men can, and actually say we're ignoring a heck of a lot of adverse health impact in women because of this bias that they can just get on with it.
Wow.
And sorry, I carry on. This is my hobby horse.
So I want to go back to two things you just said. There's a fantastic Lancet series that has come out on maternal mortality, but it's looking at the events before and the events after, and saying, actually, even when we focus on a single issue, we're missing it, because then what led up to the mortality is as significant as what happens to those who survive, because there are women who survive with tears, with prolapse, with the postpartum depression, mental health issues related to that delivery, who are terrified of the next delivery because this one was traumatic. But as soon as the baby has been pushed out and the postnatal period is over, we're done with you. But coming back to how we focus on all of these issues. So another question that keeps coming up is, but then even for the issues we're focusing on, we're hardly funded. We're woefully underfunded. Women's health generally has been woefully underfunded. But then if we expand to look at the woman holistically, then suddenly it's going to be very difficult to, it's almost stretching the soup. You have to make this meal now work for everyone. So you're a fundraiser, your other heart is a fundraiser. How do we make the business case for this investing in women holistically without us being expected to work magic with the little that's available?
So I think we have to approach it in two ways. You have to go with the heart and the mind. So the heart is about telling the stories of the relevance and importance of women in society. We have to tell those stories consistently and convincingly. As to this isn't just a nice to have, it's essential for existence of humanity that we address this agenda. So that's around the narrative, telling the stories of case studies, both where they're positive outcomes and when they're adverse outcomes. And then we have to do the maths. What is the financial implication of not improving the health outcomes and health experience of women? If your women are living a little longer but spending far more of those years in health, what is the burden on the health system of that increased lifespan in health? We need to start to articulate the investment case for those things. Why is it a good investment to ensure that the girl, and the figures, the statistics, the numbers, that the research has been done about what the value of investing in a child and getting a girl child to get her to school is, and follow her for her life course in terms of what she then contributes to the development and economy of the society she belongs to. I mean, there's studies that I think the figures I remember very articulated. If you invest $1 in a woman, you're going to get $3 back. There are very few public health interventions that have that sort of return on investment. So we need to actually, both telling the story in terms of, and I do get frustrated sometimes when you speak to people and say, yeah, we all have a mother or a sister or a wife. And I say, a woman is still valuable even if she's not related to you. But we also need to tell that stories of what women contribute when they're enabled in society. And then we need to tell the story of what happens when you don't, and then we support it with the evidence.
So I'm going to ask one last question before I open it up for questions. And we probably need to ask, I'll ask you something about how we get the men better engaged and better involved. But I started by saying it's a year of women's health. We've seen all these announcements as early as, as late as this week when Melinda French announced the $1 billion. And for me, it's causing me a lot of anxiety because the women's health gap is a global gap. And we know what happened with COVID. Global gap, we got forgotten. And I'm curious to know from your position as the CEO of the Africa Public Health Foundation, and as an advocate and also a fundraiser, what do we need to do so that then we don't get left behind, because we will get left behind?
Everything that we've talked about is what we need to do. It's about changing this narrative, changing what's the view of women by society. It's continuing to raise these issues. It's for women's health issues not to be side events, but to be core in any research gathering, in any policy gathering, in any strategy. Africa CDC, for example, now have a pillar about women's health in their strategic plan. Granted, it is still focused on maternal and reproductive health and maternal and child health, but it's a change from what it was before. And so that's an opening dialogue to have a continental focus on women. Speaking again, continue focusing on the Africa CDC as the organization I've supported for a long time. The Conference for Public Health in Africa, which is the Africa CDC's flagship conference. The first conference, which was in the middle of COVID, was virtual. We didn't have a women's track. But we had a women's side event, which had more attendees and more feedback than the core tracks. And so the next year, we were given a half day. And I challenged the organizers, and the year after that, we had a full day. So we can continue to move and push in those fora where the dialogue is had, where policy is set. And the change isn't just in the health space. The change has to be in the policy space. And that means that we need to support more women to get into politics, because public health is politics. If you're changing population health, you have a political mandate. So we need to actually have women directly engage in the political discourse. And as you would know, some of the statistics has not gone in the right direction of late. We went from a few years ago having really high representation in women in a lot of African parliaments, and it then dipped again. It's beginning to pick up, and this year is a super year for elections. The South Africans have just voted. The British, yay, we're going to get the chance to vote in a few weeks. So we need to support women into those political positions. And remember that political positions is not just prime minister, members of parliament, but in local authorities. And a lot of the decisions relevant to health are actually made closer to that local level. So we need to ensure that we enable women to actually operate in that space. And I do a lot of public health training, and one of the recommendations I make to people in public health training is adopt a politician. Find a politician that you can train to understand what you want to do about politics, what you need to change, what you need political influence to change, so that when that situation becomes topical, you don't even need to do the work, they already get it. And then us as public health professionals, we need to change our language. We know that what we're doing is good, but for a politician, he has 50 other things that he has to prioritize. So you have got to change and tell the story in a way that hits the person who has the power to make a change. And that is usually economic benefit. And is it going to win me the next election? And if you remind them that women go to the vote far more than men do. And earlier. There you go.
It's funny because the last Diagnostics Day we held at the sidelines of the public health conference in Zambia, we had the health economic advisor for the Kenya presidency on the panel, and he said the exact same thing. A, we're talking to ourselves. B, we don't know how to talk to the politicians. And C, we are so convinced that we call each other. And he actually said, I know you all know where you're going to meet next. You're going to the next conference you're going to meet. And it was true, because the next one, I think, was a HIV conference in Zambia. So, I mean, in Zimbabwe. Now, I'm going to open up for questions. Otherwise, we'll just carry on. Enya and then Kevin.
Thank you. This is kind of a personal question, but just some background. So we're working on AI-enabled ultrasound for pregnancy screening. I won't give you the whole pitch, but that's basically in a nutshell. And so when we've been implementing it, there's been great outcomes, like men are coming to ANC because we trained the AI to give like a picture of the baby. So for the first time, some men are coming and women are coming. I mean, ANC attendance is doubling and stuff like that. But while spending like months in Sierra Leone or Nigeria, where I'm implementing all of this, I'm noticing that there's some things we can't do. There's some things that AI ultrasound is just not gonna do. When the roads are destroyed by flooding, and when women just can't have enough money to get on a motorbike to come to ANC, AI is not gonna solve that problem. And it's a bit difficult to then go to the ministry and to funders and other organizations and to not bring up all these other problems. Do you have any suggestions for how to go about it, for me as a professional, but also from a public health perspective, how we should engage in conversations like this?
So thanks for that question. It's about the system. Again, I keep going on about the system, because for too long we've had our approach to public health solutions has been very vertical. We take one problem and we try and solve it. But what you've just described is that the system around that one problem, you have a solution, ultrasound scanning that is, efficient, doesn't need to have a very highly qualified ultrasonographer to do the test, and is bringing men to antenatal care because they're interested in the actual process. That's it. But that solution only works to a limit. What you've described is the system. And that is around, this is why I'm also very passionate about those of us who are looking to solve problems in public health, that we really do have a fundamental responsibility to engage with governments in the countries where we work. Because if the roads aren't working, if people's minimum income is below, survival rates, if there's the health center is too far away, it doesn't matter how good the technology if it can't be accessed effectively and affordably. So that's why bottom line is UHC, and which is why it is so disheartening that we haven't made a single tick on the priorities for UHC. So you can't look at any single solution without looking at how does it fit into the ecosystem that you want to deploy it into, because those are the barriers. So it doesn't mean that it's not a good thing. It's a good thing. It's just still not going to penetrate as far as you'd like it to go.
Hi, Kevin Teta Find. Just like to start by saying I'm an ally. Okay, so and then I wanted to ask. You'd mentioned how there was this disparity between health-seeking behavior in young children, which then establishes a process that then goes on into adulthood. And I kind of wonder, bearing in mind, not you, me generally, bearing in mind that community health workers tend generally to be women, I wonder if there is a process that we can start that education earlier and sort of make sure that engagement when they go to the household just says, well, what about your daughter? Let's take your daughter too, that kind of thing, so that even if the daughter's not is not ill, then you can drive that sort of aspect. Because I just thought what you said, it was just, it's quite stark, that sort of difference. We know that gender differences later in life, but the fact that it's established so early in life is a little bit depressing. But great that there's people like you who are driving that sort of aspect. So I don't think there's a question in there, so I think
I think it's a really good reflection and a comment, and it is actually something that is already happening. And I'm actually going to give you, because I keep emphasizing this isn't a low middle income country problem, this isn't an Africa or Asia problem, it's a global issue. In the UK, many years ago, when we introduced pertussis vaccination in pregnancy to deal with the outbreak we were seeing in newborns, initial uptake in pregnant women was very low. And then I was a local CCDC at the time, and we went to, why is this? The midwives didn't buy into it. Now, all the midwives at that time in the part of England and the north of England, they were all women, so it's not that they were anti-women thing, but they didn't buy into it because we, in designing this policy, hadn't thought about who's actually going to implement this for us. And so when we realized that there was this misunderstanding of the value and that very strong perception of risk of giving anything in pregnancy, we addressed that by actually engaging the midwives, explaining the science, and then actually charging them with the responsibility for actually educating the pregnant woman to be vaccinated. And that addressed that problem. We had the same problem with if you remember, the MMR debacle from decades ago. And we found out that primary care nurses in the UK didn't feel confident to actually reassure their patients. So we do have to look at who has contact in society, who is respected, can be a useful source of information, and bring them in as part of the solution. So community health workers, yes. Religious leaders, yes. Community traditional leaders, whoever is in a position of influence. We need to look at the system and say, who has influence here? Who do we need to address to reverse this situation? There was a story I heard about a village somewhere, I won't specify, where the local chief had only girls, and then sent all his girls to school. That changed girl registration in school, because everybody went, chief thinks it's okay to send kids to school. So everybody started sending their girls to school. So it's very important how you can, if you identify who you can use to model the behavior you want to see. So yeah, I agree with you there.
Hi, I'm Kritika. I'm with Find. Dr. Ebere, it was just lovely hearing what you had to say, and I just loved what you said about adopting a politician. Because it just made me think about how there are so many forums where we can really, well, if not adopt a politician, at least train people to think the way that, to talk about prioritizing women and girls. And I was just thinking about how, as the G20, for example, talks about women and girls, but it's very much on the sidelines. But we have heard that as the presidency is going to transition to South Africa, that this could be a priority that South Africa would look at, ensuring that we prioritize the health of women and girls. I'd love to hear your thoughts on how we can support that and how we can make sure that women and girls take center stage in South Africa.
I'm going to answer that by just asking for a show of hands. Who in this room is not in public health? Hey, that's actually a lot better than. May I ask which sector you're from? Because I might actually tell you are in public health, but yeah. Well, that's public health. So the thing is, so the first thing we need to do is stop talking to ourselves. We need to actually, the main reason I went to work for the Tony Blair Institute was I left Public Health England and said, I need to talk to the people who actually make the decisions. So I wanted to understand how to engage with politicians. And we need to, it's great to share knowledge amongst ourselves, but after doing that, then you actually need to go and find an audience who don't know what we know already. And that's why I keep saying adopt a politician. The most effective TB social interventions I managed to get in working in the north of England was I didn't actually have to speak. I wasn't in the room when the decision was made by the local authority because the politician I'd been working with for many years, when the opportunity arose, she stood up and she spoke with confidence and knowledge. And then she rang me afterwards and said, this came up and I've done that and we're going to sign, we're going to start providing housing to MDR TB patients. That was amazing for us because we couldn't get MDR TB patients complete treatment because they had no housing. So we need to learn to find avenues and opportunities and platforms where we might be the only person who understands that subject matter and communicates in a way that reaches people. And as you know, I use stories a lot because you need to humanize the situation. It doesn't have to be personalized, but you have to humanize the situation to gain the attention, and then you have to be ready with your facts. And not just the facts about how bad it is, but the facts about how good it could be, because people like to see themselves as part of the solution. So it's about broadening the audience that we engage with. Politicians are a key one, but we also need to recognize that politicians are put in place by electorates, which is my other passion, is that we need to move away from situations where people can win elections without having a single sentence about health in their manifesto. And it should also be that you shouldn't win an election if you haven't got a clear strategy about women and girls. So we need to actually start to get our electorate to hold their local, from local to national to regional, whatever political tier, to ask about, this is important to me, what are you doing about it?
We had earlier, from the earlier panel, that one of the major causes of this fragmentation in their disease area, but particularly in women's health, is the donors. So how do we get the donors then to speak, to think holistically? Because we've been talking about the politicians and the governments, but how do we get the donors to think about a woman holistically?
So yesterday, this came up in a conversation I was having about the perception that donors are driving the agenda because they have the money. I, having had the privilege of working with quite a number of donors, realized that donors drive the agenda when you haven't set it. So if the page is empty, they will fill it. But if we actually get better at articulating what we want, so I'll use the example of, because we can actually brag about our health minister at the moment in Nigeria. We have a great health minister who's come up with a very clear strategy about what he wants to happen. So all donors are just saying, where do I fall in line? So if you define the agenda, you set the agenda, donors will fall. It's when we don't that they say, oh, well, this is what I'll do, I'll support that. But even when they do that, again, it's about making the case in the language. Donors, too, have a constituency. Even when they're, like Melinda Gates and the money's all theirs, there's still people they want to be happy with what they're doing. So we need to actually make the case in the language that donor needs to be able to take home and say, okay, this is actually what we are about. It is going to change. It's going to result in the outcomes we want to see. So I don't think that donors are as single-minded as we like to suggest they are. It absolves us of responsibility, I think, of where we haven't really articulated we haven't been bold in challenging what the priority should be.
We have time for, and there's another one at the back.
I've asked a number of questions.
Okay.
Claire Wingfield, also from FIND. This is really wonderful to hear, and as you were talking, I was reflecting, as a woman who has made a conscious decision to never have a child, you know, the people I actually find to be the ones to tell me, like, well, you don't know, you're not mother, or I'm sort of only my bits, are women.
Yeah.
And I'd love to hear some of your reflections as a public health leader, sort of you encountering that or hearing that kind of narrative, and sort of what your reaction or what you have seen work to kind of really also change. I have found that women sometimes can be my worst enemy. That I'm like what I'm asking for isn't enough.
Right, okay. I'm going to answer that from a personal perspective. I have a daughter who is in her late 20s who declared very early on that she doesn't think she wants to be a mother. And I went, that's absolutely fine. You don't have to be. I had only one child, and I thought, thank you very much. That was enough for me. I'm not going through that trauma again. We talked about trauma. We talked about the trauma. And I know the number of times you told me, once the baby comes out, you forget about it, you'll be fine. Again, that isn't necessarily true. I can still remember. So it's a hard one. Women are part of the society. Just because we're the ones who suffer the adverse effects of whatever it is that society doesn't do right by us, doesn't mean we can't still be part of propagating that status quo. Because that's what, my grandmother knew that, her mother knew that, my mother knew that is the expectation, that is the way it is for women, But we can change that one bold step by other. So I am my daughter's strongest advocate. If she doesn't want to have children, that is absolutely fine. She's also, from a family of health professionals and academics, she is an actor. And I don't know about you, how many of you know Nigerians, but, if you're not a doctor, a pharmacist, a lawyer, people question your intelligence. But my job was to step into that breach and say, if you have a problem with her, you have a problem with me. And I'm quite intimidating. But we have to change that as people start to recognize the completeness of women. And that is about being willing, able, and using platforms to actually share the stories of women beyond motherhood and beyond parenting, or even beyond being a wife and all those other traditional roles we're giving, to say you can be those things, it's not wrong, but you can also choose not to be those things, and it doesn't make you a lesser person. So it's about that whole picture of what people can be.
Emmanuel Ogogo. So there's an idea that recently talking to someone, they mentioned about responsible fatherhood. And I think, it's in line with what you've said about, having a different type of champion. So how do you think that can apply to the whole of life approach if you were to unpack, the concept of a responsible father?
I actually object to the concept of responsible fatherhood, unless you also put responsible in front of motherhood. All parenting should be responsible. So it doesn't have to be an extra label because it's a father. So again, I was at a women's conference in Rwanda a few years ago where there was a talk about supporting women in the workplace, and this young man stood up and went on about how when his wife was studying for her PhD, he said, I helped her by looking after the children and everything. And I stood up and said, they're your children. You're not helping, you're doing your job. So it's about changing, when it's a woman doing it, it's just what she does. But when a man does it, oh, wow, Yeah. So we need to stop seeing it as an add-on for men. If you're going to be a parent, be a parent. That means bring your whole self and everything you can offer to that parenting role. And that's about, and Chimamanda Adichie wrote about it. She wrote a little pamphlet about how to raise a feminist. And she talks about how to raise a feminist son. And she talks about the fact that it's important from the get-go not to raise the son to think that he's special and different or that there are things he shouldn't do. The best chef in my family is my nephew. My daughter, if there's takeaway, she's not cooking. And that's absolutely fine. She had no interest. Why should I make her? I like cooking. She doesn't. He likes cooking. He's a really great chef. And so we need to normalize. We need to start looking at these gendered roles in society and in the family and ask ourselves, is that real? Or is it something that we should actually start to change? So we all have a duty, if we're involved and engaged with children in particular, that the next generation, so we're not still having this conversation in 100 years, to actually ask, what are we telling, what are we modeling for our children that makes them feel that changing their children's diaper, the men feel that changing the baby's diaper is an achievement? We could go on, but I have got to go.
So in closing, what's the magic bullet? What's the one thing you would like this audience to take away to start looking at or to start championing a whole of life approach?
Leadership. It's about leadership. Leaders make the space for things to change. And so we need more women in leadership. We need allies, men as allies in leadership. And the male allies, I always say to you, please, whenever you're in any space, look around and say who's missing. And if you have a chair and you know a woman who can take that chair, stand up and give it up for that woman. And the more we have leaders who continue to talk about the representation of women in all spheres confidently, then the more likely things are to change.
Thank you, Dr. Okereke.
Thanks for having me.